One. Welcome back, everybody, and thank you for joining us again on the EYE show. I'm Dr. Sandy Laura Cremers, one of the eye surgeons here at Visionary Eye Doctors, and thank you for subscribing and joining us for podcast number 19. We are very happy to welcome Dr. Steve Maskin, one of the world's most well-known researchers and contributors to the field of dry eye research and treatment. Dr. Maskin, you know I've been a big fan of yours for many years and have been following your research, so it's a real honor to be able to talk to you today about your life's journey into this field. And just a little background on Dr. Maskin. I've known of him for many years. He is well known in the field of ophthalmology, having a practice that's well known in Tampa, Florida. It's called the Dry Eye and Cornea Treatment Center in Tampa, Florida, and sees patients around the world that fly in just to see him. He was a clinical fellow in cornea and external diseases at Bascom Palmer and received an NIH grant for ocular surface disease there. He was the recipient of the very prestigious 2019 American Academy of Ophthalmology Achievement Award, is also a courtesy professor at the Department of Medical Engineering at USF, has 6 patents related to meibomian gland dysfunction, and the inventor of the intraductal meibomian gland probe, and the procedures that involve the discovery of this constricting preductal fibrosis theory, which I think we can say it's proven to some extent on meibomian glands, but still a little controversial, has 22 published peer-reviewed papers, and the author of Reversing Dry Eye Syndrome, Practical Ways to Improve Your Comfort, Vision, and Appearance from Yale University Press, and a new edition is about to be released. And he is a frequent contributor and presenter at the American Academy of Ophthalmology's annual conference, as well as ARVO and the World Corneal Congress. So thank you for joining me, Dr. Maskin.
Well, thank you for having me, and congratulations on the success of your program.
Thank you.
Education is vital today for lay public to learn about their medical problems, and what you're doing is exemplary. Thank you.
Thank you. It was nice to speak to you a little bit before the podcast started about your work that you started in 2000s about really arming patients with the tools they need to understand their disease process and helping everyone, especially, women that you mentioned that you had this particular radio show in the 2000s. That was very interesting to hear of your work on that. So that must have been part of your journey into medicine. So how did you get involved? How did you get an interest in medicine?
Well, back in high school, I had a physics teacher in 12th grade ask me whether when I was confronted with a problem, whether I wanted to solve the problem with using as few resources as possible and getting a good solution to it, or did I want the best solution no matter the cost? And so in 12th grade, I said I just wanted the right solution, the correct solution, no matter the cost. And he said, well, you're a scientist, you're not an engineer. So with my interest in math and science, and with that, I decided, that medicine probably was the right course for me. I always looked at medicine not so much, as a science, from a scientific perspective, in addition to the clinical opportunity to help patients, but in a scientific approach.
And how did you get involved in ophthalmology? What kind of interested you with ophthalmology?
Well, going through medical school, everything appealed to me equally, but I didn't really find something I was passionate about until I picked up a book on ocular pathology, and that was my 4th year. And I read that. You may be familiar with the book by Yanoff and Fine. This goes back several years. I read it cover to cover in about a week and a half, and I followed that up with an internship at the AFIP under Lorenz Zimmerman, who is well known, of course, as a ophthalmic pathologist. And I spent a month with him, and I decided at that point this is really what I wanted to pursue. And next thing, I applied to residencies and started my ophthalmic career.
That's great. And how about dry eye? What kind of moved you in that path?
Well, during residency, I enjoyed the corneal transplants. I enjoyed being able to make a difference in people's lives. And that really was the thing that attracted me to the cornea external disease subspecialty. Dry eye wasn't particularly a focus of mine until I got into fellowship. And in my fellowship, I began my fellowship growing meibomian glands, rabbit meibomian glands in vitro, and studying them. I didn't really understand the magnitude, the importance, the challenge of dry eye until I got into private practice, because at the time we really didn't have consistently successful therapies for MGD. So as we managed the other aspects of dry eye, whether it be aqueous tear deficiency, allergy, other surface diseases, we could only get the patient to a certain level of comfort. And we got stuck when the residual symptoms were secondary to MGD. So this challenge, at some point, I decided that that this was the breakthrough. This is the area that really need to focus upon and identify the missing link. Why this is such a mystery to, a lot of research had been carried out on meibomian glands, and yet we were still stuck with the same approaches of, antibiotics, steroid, lid hygiene, and the results were frustrating for everybody, patients as well as physicians.
What were some of the treatments available at that time that you had? Or what was the only treatments you had?
You talk about lid hygiene, so warm compresses, lid scrubs, right?
That was it, right?
And that's it. You use top antibiotic ointment for heavy crusting of the lid margins and lashes, topical steroid, and that was about all that was we were able to offer.
And so describe the process of how you finally kind of went through that research to have a theory about the intraductal fibrosis, the epithelial cells that you feel go into the meibomian glands and destroy it. We've talked before about how you think it's really a race against time. And if we don't get to the meibomian gland in time, that scar tissue will set in and the game is over. How did you research that process?
If I could, as an aside, I don't know if we can. I lost your picture. I lost your video feed.
I see. Did you hear the question about the process of how you actually kind of were able to kind of discover the process of the intraductal fibrosis?
Yes. There you go. Thank you. I would have, patients would come in and they would have MGD and the conventional therapies were unsuccessful. I felt, this was in the early 2000s to mid 2000s, I felt that the answer lay inside the meibomian glands. We needed more data. I needed more data to understand what was going on, why the glands would get obstructed, because the conventional theory at the time was the gland would get obstructed through a thickening of the meibum, or keratinization of the ductal epithelial cells blocking the outflow. So despite that, and despite the warm compresses, which one would think would melt the thickened meibum and achieve success clinically, still patients were not achieving success, uniform success. So I thought that there was other information in the data that we didn't have. And we need to acquire it. And the only way I knew to do that was to actually go inside the gland. I didn't know what to expect, but I decided to create a prototype probe to go inside the gland. I didn't know, again, what I would find there. But when I went in, I remember the patient, actually. It was a middle-aged gentleman, pretty overweight, but the glands looked congested. And he was crying out in pain. He couldn't live with it anymore. And I, explained to him what I would hope to do is to get more information that we could ultimately help him. And the way to get more information was to go inside that tissue, go inside that gland, and maybe learn something that could help him. After informed consent, I did just that. I put a sterile prototype probe in there, and the probe met up against a fixed resistance. And I thought that was odd. And with a little pressure, I was able... Well, I heard a pop. We both heard a pop. The patient and I, we both heard a pop. And meibum started trickling out along the wire probe, egressing through the orifice and out. And with that, he said, that felt good. I felt some relief there. So did the next gland, and it was consistent. The experience was consistent. Pop, oil came out, patient felt better, lids were less tender. And I'm thinking that, wait a minute, we're taught that the glands get obstructed by hardened or solidified or thick meibum or keratinized cells. That would not present a fixed resistance. My stainless steel wire probe should just pass through there. Even if it was thickened, it should pass through there. but it didn't. And the sensory and auditory findings from passing that probe was the same as though you were trying to open up a scar in the punctum, the punctal outflow tract, where you get that pop, and your probe would go right through into the canaliculus. So it became clear to me that we were looking at more of a fibrotic reaction that, in turn, we were able to release as we were passing the probe through the duct, similar to like the snap of an old rubber band. It would open up, the duct would open up when we passed the probe through the duct, and so the periductal fibrosis, which is wrapped around the duct wall, able to be released and restore the integrity of the duct. So now the probe can pass freely to and fro, and with that, you have an immediate equilibration of pressures on either side of the fibrosis, and the tenderness goes away dramatically and immediately, because the lid tenderness, which again through the experience of probing, I just found that lid tenderness is a marker of elevated pressure, and it goes and is relieved immediately after you equilibrate pressures by releasing that scar tissue with the probing. So things start falling into place and started making a lot of sense now. So the experience with that gentleman was repeated on patient after patient after patient. And back then I was interested in looking at those patients with lid tenderness, because those are the ones that have that wow factor when you perform the probing for those patients. And I wanted to I was interested in convincing myself one way or the other. I wanted to either prove or disprove the hypothesis that this fibrotic reaction caused the elevated pressure, caused the lid tenderness. And over again, it was a consistent result. You probe these glands, release the scar tissue, patient's lid tenderness goes away dramatically.
How would you then, in terms of your experience seeing so many patients globally, how do you define dry eye disease exactly? What is your definition? We, of course, have the many international definitions, but what is your personal definition?
Yeah. I look at it as an abnormality of the tear glands, tear film, or ocular surface, leading to symptoms and or signs of ocular surface disease. I was thinking about this last night, actually, how to define it. But to me, dry eye is such a insufficient term and doesn't adequately describe what we're dealing with when our patients come to us for help. So to me, that kind of captures, I think, what I view as dry eye disease, what we commonly think of as dry eye disease: abnormality of the tear glands, tear film, or ocular surface, leading to symptoms and or signs of ocular surface disease. Because we know that sometimes there's signs and no symptoms, sometimes there's symptoms and a few signs. So that's what I would propose.
Are there any patients that are not candidates for probing?
We did a study in 2019, we published in Cornea, showing that in lids with MGD, 67% of glands in those lids have fixed fibrosis at 1 millimeter. So if we probe those glands in lids with MGD to 2 and 4 millimeters, it turns out that over 90% of glands have some periductal fibrosis at some level of that gland. So, and we know that this disease progresses in an asymptomatic way. So for me, if you have MGD, you should be probed.
So this is the picture, I'm sure you have this in your office also, of, just so the patients that are watching on YouTube, the people that are listening on the podcast, I'm holding up that picture of normal meibography, a normal meibomian gland anatomy, and what happens. And so how many glands are we born with on the upper and lower lid?
Well, we have between 25 to 35 in each lid, although, as you, I'm sure, have seen too, they can have double rows, and they can have 50 or more glands.
That's right.
And you can imagine how crowded that lid is, which would increase the risk factor to, for flow, for consistently good flow, and increasing the risk factor for more, periductal fibrosis and obstruction.
So at what point, so we have the normal at the top and then very abnormal at the bottom, that progression of seeing these kind of white lines filled with oil on the mammography kind of drying up. When do you say there's MGD? Do you say it when there's a decrease in one of the glands or a full gland, or what's your definition of when you would probe a patient? And let's say that, of course, they're symptomatic and asymptomatic, and we've seen obviously both a variety of patients that have terrible signs of dry eye but have no symptoms. And then you show them their glands and they can't believe that they have a problem. And so at what point do you say this is clearly meibomian gland dysfunction?
Well, clearly when you have dilated ducts on mammography, you can show that that's the patient and show them that they have obstruction.
So kind of like
before, even before you have atrophy, you can show the dilated ducts, showing that there's back pressure and the ducts will dilate. But even with a normal mammography, if we see telangiectasia, if we see retroplacement of the orifice, meibomian orifices, I don't rely. I mean, in the setting of a completely normal mammography, but a symptomatic patient, that patient should be probed, and I would diagnose that patient with MGD even with a normal mammography. So I wouldn't wait till the patient started losing gland tissue to probe them.
And so I've read some of your papers about how you've used confocal microscopy to kind of show that there is an epithelial layer that goes into the gland and starts to clog it up. So in a patient like this, let's see if we have a gland that's kind of starting to thin out. Is it a combination of the epithelial cells going into the orifice and closing the orifice? Or is it also internal that's constricting? Is it epithelials just inside the lumen, or do you think there's a structure outside of the actual lumen that's constricting the actual?
Well, yeah, there's two things going on. Okay, in that paper we published in 2019, the periductal fibrosis presents a constricting phenomena. So it grows around the gland and the duct and constricts, and by doing so, it compromises the integrity of the lumen of the duct. But that fibrosis can also invade, and you can see a scalloping of the duct wall. And with that invasion, that is felt to be the stem cell zone of the meibomian gland in the outer duct wall epithelial cells. So I think that we ultimately can see atrophy from one of those two mechanisms: the invasion of the stem cell zone, or which could be asymptomatic, which could actually be an asymptomatic progression of disease until enough gland tissue is lost, or the more symptomatic presentation where you have a constricting of the duct wall from the fibrosis, which elevates the intraductal pressure. And I think ultimately it's a combination of both. I think we see patients with combination of both. Some glands can have a combination of both. Individual glands can have a combination of both. Different glands in the same lid can have a combination of both. But those are the two pathophysiologic mechanisms that I see happening due to the periductal fibrosis activity.
We've talked a little bit about this recent paper we published on the children that had increased atrophy, partly related to screen time. A concern was that some of their autoimmune antibody factors were positive, even though we didn't achieve statistical significance because it was a small study. You and I have seen patients with autoimmune disease that clearly have that really quick atrophy. And so in those patients, is it also just periductal fibrosis, the same process, or is there something also making it go faster? Do you know what I mean? You might not even see telangiectasia in these autoimmune disease patients, but they clearly have an atrophy going on internally. Well,
that's where the topic of comorbid disease is so important. The autoimmune disease can attack the meibomian glands. They can create this periductal fibrosis, but we can't lose sight of the fact that the meibomian glands require healthy systems to optimize their function, particularly the aqueous tear system. So we're talking about autoimmune disease, we have to talk about the aqueous tear system. The aqueous provides the support for meibomian glands similar to saliva providing support for teeth in the dental analogy. No saliva, eventually no teeth. No aqueous tear, eventually you'll lose your meibomian glands. So autoimmune disease, I'm thinking about aqueous tear deficiency as well. I'm thinking about potential allergic component. I'm thinking about other ocular surface diseases. I want to be sure the microbiology, there's no infectious component. So I think that the incidence of comorbid diseases in that subset of patients is even greater and can generate a more rapid level of atrophy or progression of atrophy of the meibomian glands in a more rapid way. Plus the inflammation, I mean, it tends to be greater in the lid with those autoimmune diseases. So you talk about that nice paper you published about children. You know, we can talk about graft-versus-host disease. We can talk about pemphigoid in adults. These patients require aggressive therapies because they get a lot of fibrosis, a lot of periductal fibrosis, and they require probing to release that periductal fibrosis. That is the best way to release that periductal fibrosis is with probing. But they need support. They need systemic therapy, for example, pemphigoid patients, to minimize that inflammatory reaction to slow the return of that periductal fibrosis. Okay, to preserve those glands, they need some systemic support, and we also again need to identify those comorbid diseases that we talked about.
That's right. So just to remind our listeners and viewers, the tear film has the three parts: the oil that comes from these meibomian glands, the water that comes from the lacrimal gland located kind of under your orbit, and the mucin, which mixes the oil and water together. And all three are probably affected by autoimmune disease. And this process, we can only image right now the meibomian glands. We're not really much closer to imaging the lacrimal gland or the assessment of the mucin layer or goblet cells that I know of. I think that's kind of like the last frontier.
Except for vital staining, Rose-Bango, that's about
as good as it gets, right?
Yeah.
So this is the one place we can clearly show how we all dry up as we get older, and we can clearly show patients that process. So in your process of probing, what is your protocol now in terms of using the 1 millimeter, the 3 millimeter, the 4 millimeter, the 1 millimeter, 2 millimeter, or 4 millimeter probe? How do you actually go about that now with patients?
Well, the first step is anesthesia to make the patient comfortable. And for me, I use the jojoba anesthetic ointment. It's topical. Sometimes I give 2 rounds of the ointment. I first begin with a drop of topical anesthetic, proparacaine, tetracaine, then I place a bandage contact lens. And then when the patient in a reclined position in the exam chair, I put the jojoba anesthetic ointment on the lower lid margin and have the patient close their eyes. About 5 minutes, they put a second dose on the lower lid margin. Those patients that are very delicate, very severe, very sensitive, we use infiltrative anesthesia, kind of like what's used for cosmetic lid surgery. Same idea. You can use 2% lidocaine with epinephrine. You can inject it to the lid margin, to the lash line. You can inject some in the fornix. But more recently, I've been actually looking at supraorbital and infraorbital nerve block, which the supraorbital nerve obviously exits at the supraorbital notch, which is in the brow area, and the corresponding infraorbital foramen just below the inferior orbit in this area here. And so I've been looking at that for the last couple of months, and those very, very sensitive patients, so far I like what I see. It keeps the lids, free of the infiltrative anesthetic, and so I'm going to continue to pursue that and see for those special patients that need a little extra support anesthetic-wise. After numbing the patient, then the patient is brought to the slit lamp, and I always use the 1 millimeter probe first because it's the shortest and stiffest, and has the greatest likelihood of finding that correct entry angle to get through the orifice into the distal duct. If there's persistent lid tenderness afterward, then I will go deeper to 2 and 4 millimeter probe. This is so important, the fact that you can have pain, severe pain, to the level of suicidal level, 10 out of 10, from meibomian gland obstruction, from a fixed obstruction. It's so important to understand that. And I mean, we have colleagues that use the so-called proparacaine test, where they put a drop of proparacaine on the eye in these patients with severe suicidal level pain. And if the pain persists after the proparacaine or tetracaine, they diagnose neuropathic pain. But I can tell you that topical anesthesia is not going to numb the meibomian glands.
Mm-hmm.
The meibomian glands, pain from those glands will persist in the setting of topical anesthetic, of proparacaine drop or a tetracaine drop.
Even if they don't have lid tenderness?
Yes, even if they don't have lid tenderness. I wouldn't, that's usually there, but not always there.
Okay.
So probing is actually diagnostic as well as therapeutic, and can help in that setting to sort out the source of the pain. So recently had a case where I needed to go with 4 millimeters to release some occult blockage. And it's interesting, patients describe these symptoms differently.
Mm-hmm.
Patients may say their lid's burning and not claim lid tenderness, not describe the lid tenderness. So I think we have to, even though the usual patient presents usually, right, the typical complaints, not always the case. So if things don't make sense, we've got to go back to the fundamentals. And we know that occult meibomian gland disease can lead to pain.
Do you express between the 1 millimeter and then see if you need to do the 2 or 4 millimeter? Do you express right after the 1 millimeter?
Yeah, I usually do express gently.
And what's your favorite way to express?
I use the Maskin expressor,
Mm-hmm.
Which is basically 2 rollers.
Mm-hmm.
And so I use that to kind of milk the meibum out. And sometimes there may not be a lot of oil there, and that's okay too,
mm-hmm.
because that means that gland had been shut down. But now we've released the scar tissue, we've created a healthier microenvironment, and that gland can come back.
How often do you probe?
I probe annually to maintain the progress, and that's very important. Even if the patient doesn't have symptoms, it's important to probe every year because, again, this disease progresses in an asymptomatic way. But just as we published in the first paper in 210, even if you're asymptomatic, you still have changes. What I mean by that is that once you probe these asymptomatic patients, they will often come back and say, my eye feels better. I didn't realize that I was living with my lid not move when I blink, it dragging on my ocular surface, or I had some irritation, my vision was not quite as consistent as it is now. They will tell you that it feels better. My eye feels better, performs better, I'm seeing better after probing, even though they didn't realize at the time that they had these symptoms. So I've had patients tell me, and after their maintenance probing, asymptomatic, but they clearly state that it feels significantly better after that probing.
Is there a patient that you had to probe every single week or every 2 weeks, or what's the closest that you've ever probed?
That's a great question. That's a great question. If you're finding that you're having to probe at that juncture, let's say less than 2 months apart or 3 months apart, then there's some comorbid diseases. There's some comorbid disease or diseases that's stimulating that scar tissue to recur, to reblock that gland. Probing should last 8 to 12 months. One treatment should last 8 to 12 months. If it doesn't, and typically it's about 2 to 3 months, that the comorbid diseases will lead to that gland reobstructing from the scar tissue. Now, if the patient gets better and then 2 weeks later starts to have more symptoms, I would bring them in and I would look and examine. It could be maybe they start having some crusting. Maybe they were exposed to something they're allergic to. But there's something that triggered an exacerbation of that periductal fibrosis, so it reaccumulated and starts squeezing again and constricting again around the duct.
Mm-hmm.
So if we catch it early and treat it, then we can reverse it. Doesn't need to be probed again.
Mm-hmm. When do you actually insert steroids into the meibomian gland, and are there other biologics that you're inserting?
So the introduction of the intraductal therapeutics is very important. I know you've done a lot of work in that area too, and it's something that we both know has a great potential in the future as well as we can offer today. I use dexamethasone, so it's steroid. I do use autologous serum, depending upon the indications. And the so I find that autologous serum, for example, in patients that tend to show a more rapid recurrence of their periductal fibrosis, I find that autologous serum can slow that process down. In the case of dexamethasone, that again, if cases that are inflamed, that have significant comorbid diseases, the lavage of intraductal steroid, dexamethasone, can help with controlling that inflammatory reaction. It's also when we lavage or introduce these intraductal therapeutics, we can also use it as a lavage. In other words, we can help irrigate out some of the residual debris and meibum that is trapped in there or stuck in there. So it really is twofold. The intraductal therapeutics can clean it out, the intraductal space out, as well as introduce a pharmaceutical effect.
If you find the orifice is completely closed, do you push through, or you just know it's scarred? You know it's scarred. Let's say it's like a patient like this. There's a little bit, maybe there's a stem cell left, or maybe it's just pure scar. And you are there, you can see that there was an orifice and it's completely kind of closed off. What do you do?
There's an orifice, I'm probing it. And we showed that in the 220 paper in British Journal of Ophthalmology, that you have a gland or a space that looks like what we call whole gland atrophy. You don't see any acinoductal units at all. If there's an orifice there, then it turns out that there's still a duct there.
And so it kind of like, you might not even see this, you're saying.
That's right.
Okay.
That's right. As long as there's an orifice, it may be just a little smidge. Well, that smidge may be hundreds of cells, for all we know.
That's true. That's true. That is a theory, that if there's one stem cell left, you have a chance maybe to grow it back. That's true. Now, what if there's nothing? What if there's completely, scarred over?
Well, if there's no orifice, then there's nothing there to probe.
Okay.
There's no orifice.
And that's a travesty. I mean, that's really a travesty. I think that's the saddest thing I've seen is when you see that gland completely destroyed and you start to see the blood vessels growing on the cornea and you know which way this is heading. That's very hard to see. Yes,
that's right. So in that case, any gland that we can save, and it becomes obviously worthwhile. So if a patient has 2 glands left, we can turn those into hypersecretors and have some level of comfort for the patient.
That's a good point. Yep.
Going all out for.
Yeah, we've had patients, same thing, that have minimal symptoms because they have 1 gland left. And that's kind of like, and we have other patients, as you know, that have literally terrible disease when they just lose 1 gland. It's very interesting that way. That can be very interesting. So what do you think the role of Lipiflow and IPL? I know this is very hot spot to ask of. I know it's controversial. So tell me your opinion about Lipiflow and IPL.
Well, I think the focus, I've been managing MGD since the late 80s. Okay. And my understanding of the proximate cause of this disease is based on that experience. It started with that experience with that middle-aged gentleman who was here crying out in pain from his meibomian glands. And dramatically and immediately, he was relieved of his pain by simply releasing the scar tissue. So I know that periductal fibrosis is key to controlling this disease. Complementary therapies like IPL and Lipiflow, I think have their place, but I think that if we do not release that scar tissue, and as a first line of therapy, then we're compromising the quality of care because we're allowing that scar tissue and its sequela to run its course, which means atrophy behind that scar tissue. Now, if the scar tissue is midway along the gland length, so we wind up losing the gland proximal to it, and we wind up with short glands, truncated glands.
Yep.
If the scar tissue is just inside the orifice and it's not released, then we lose the entire gland.
Mm-hmm.
So I think that the first thing we need to do as clinicians is to restore patency of the gland duct. For example, if we had a common bile duct stone,
mm-hmm.
we're not going to leave it in there and maybe take medications to thin out the bile. You know, we got a stone in there, we want to remove the stone because ultimately it's going to cause problems in our biliary system,
mm-hmm.
our hepatic system. So I think if we focus on the pathology, what's wrong, and we restore patency and ductal integrity, then we can think about, okay, how do we maximize the outflow from that gland? Now that the gland and duct are open, how do we deliver the maximum amount of meibum? How do we reduce inflammation? The kinds of things that the Lipiflow and IPL therapies are focused on doing.
Mm-hmm.
But I think that it begins with restoring the system to where it was intended to be, which means an open, patent system.
So the paper by the South Korean group, Hwang et al., about doing the probing first and the IPL after to kind of keep it pumping, you would agree that that's not a bad protocol to follow?
I think that should be looked at. Okay. I think that idea has some merit. That paper showed, for example, we talked about lid tenderness mm-hmm. and how the meibomian glands, when they get obstructed with this periductal fibrosis, increases lid tenderness. And that paper showed that in the meibomian gland probing group versus the IPL group, that the improvement with probing was statistically significant mm-hmm. as far as reduction of lid tenderness. I mean, there were also other favorable findings in that paper mm-hmm, too, mm-hmm. whereas at 6 months, 35% of patients that were treated with IPL alone required retreatment, whereas only 20% of the probing alone patients required retreatment. Mm-hmm. And of course, a treatment with IPL is considered 3 sessions, whereas a treatment with probing is one time. Mm-hmm. And there are also other findings too, with that the probing alone group seemed to exceed the IPL alone group as far as tear breakup time and speed result reduction symptoms. But I think, again, these are things that we sorted out as time goes by. But I think the major thrust of this is to when a patient has MGD, we know that it's an obstructive disease. The first thing to do is to restore the integrity of the outflow tract by releasing the scar tissue. Mm-hmm. And then looking at complementary therapies. That approach makes sense.
Very good point. And the paper you were not involved in at all, nor was Dr. Toyos, which was very nice because it was the first really objective prospective study to compare IPL intense pulse light with just probing and then combined together. So we're on the right track in trying to find the help that patients need. And it's kind of like the Wild West, like what is the best way? And we know we're seeing this train wreck happening in front of our eyes. I know you're seeing it too with all the children coming through with the screen time. Can you comment on what you think about the blue light, even though we don't have data, screen time, blinking? What are your thoughts on the blue light, even though we don't have data on it yet? One
final point on the Hwang paper. There's a lot of, all the papers on meibomian gland probing in the literature are positive, universally positive. And the investigators laud the probing technique and the results, and these are all patients that were refractory to standard of care up until entry into the meibomian gland into these studies. But having said that, there's deviations in protocol from study to study. Mm-hmm. So, for example, the Hwang paper got great results despite the fact that they injected anesthesia 4% lidocaine, which is something we don't do in the States because, again, it's very harsh to inject 4%. The probes they used and the tubes they used, because they injected as well, were significantly larger than the ones that I developed dimensioned for the glands themselves. The point being is that that when evaluating these studies, understand it's deviations in protocol. So just the fact that they got good results, it could be even better with following the protocol that we've established.
Good point.
More comfortable for the patients and possibly better results as well. To your question, as far as blue light, it makes sense, for some patients that are sensitive to blue light, and it's easily evaluated with, blue light blocking glasses at the computers, for example. So, I look at treatment of dry eye as a big jigsaw puzzle, where there are large pieces to this puzzle and there are small pieces to the puzzle. And for me, the large pieces of the puzzle, to try to put things back together, the large pieces of the puzzle are three main systems: the ocular surface, the aqueous tear system, and the meibomian gland oil system. If we get those three things right and restore a healthy anatomy and physiology of those three things, then we're way ahead. So then the smaller pieces, they're significant, but they're smaller. They add to the continued improvement of comfort. These comorbidities, anterior blepharitis, allergy, khaleesis, those things are additive and in some ways synergistic to the establishment of a healthy water, tear, oil, meibomian gland, and ocular surface disease. So if we put all these together, and for example, blue light, a patient sensitive to blue light, if the patient has food allergies, all these things are additive to the major components, the larger pieces of that jigsaw puzzle. So I always start with the large ones because patients, and you've had this experience too, I know, patients come and they tell me, if you can't help me, I'm checking out. I can't live with this anymore. So I always focus on the large stuff first. I'm not going to tell them, try blue blocking glasses. They look at me like crazy, like, I'm going to jump off a cliff and you're telling me this. So I always start with the big stuff first, and then once I get them 50, 80% better, then I start adding the other stuff, yes, I'll add allergy therapy if I think they're allergic right from the start, but my focus is on the restoring the healthy anatomy, of the ocular surface, releasing the meibomian gland periductal fibrosis, getting optimal aqueous tear, and then adding, looking at allergy, looking at nocturnal leg ophthalmos, looking at anterior blepharitis, do all those things too. But the same way, like we said, dietary. I'm sorry.
You mentioned conjunctival khaleesis, which are the folds in the conjunctiva, the clear covering of the white part of the eye that do develop folds from time to time with aging. When do you actually surgically intervene and treat it?
If it's symptomatic, then I treat it. So I don't look at I can look at a patient and I see the folds, and they could be inferiorly, they could have temporal folds, they could have superior khaleesis. But just because the folds are there doesn't mean they're symptomatic. So I look to evaluate the level of symptoms. If they're symptomatic from the folds, then I will suggest treatment. I try to elicit, to understand the impact of this tissue, of khaleesis on the patient. I try to elicit symptoms. I try to neutralize the symptoms. For example, if they have folds on the lower lid margin, typical complaint would be heavy and tired eyes, heavy and tired lids, heavy and tired eyes. They may also complain of dampness or moisture in the outer canthal area on the skin, as the folds there will channel the tears rather than across the ocular surface toward the nose and the punctum. They'll channel the tears to the outer canthus and the skin. So if patients have that complaint, then I will look and evaluate the complaint of heavy and tiredness. So I will sit at the slit lamp. I will simply evert the lower lid temporally and ask them if there's a change in their symptom. And they'll typically say there's less heavy and tiredness. Just simply by letting that khaleesis tissue drop, there's less heaviness and tiredness. So as far as I'm concerned, at that point, they're a candidate for repair of that tissue.
What's your favorite way to repair it?
I like using amniotic membrane. I like being able to remove as much abnormal tissue as they have, and without concern about foreshortening the fornix. And so for me, I take them to the operating room. I excise the tissue, and I use amniotic membrane, tailor it to fit the area that's necessary to reconstruct, and that's my approach. I use fibrin glue, fibrin adhesive, and suture, and it leaves the patient with a smooth surface. Now, the other thing nice about the amniotic membrane, of course, it has intrinsic growth factors, which suppress inflammation, suppress fibrosis, and angiogenesis. So you have that added benefit as well, which I think in the long run is beneficial to the patient, as opposed to, and I know, another approach would be just a snip and maybe stitch. But again, I've had patients come to me from elsewhere having had that done, and they just have ongoing problems. And I prefer just to take care of it once and for all and move on. Like I tell patients, we do this one time, and you don't have to deal with that for the rest of your life. The area that we reconstruct, you're done with that. We don't have to redo that. So it's a one and done.
So we talked a little bit about your what's your routine for cleaning your eyes, and what's your eye regimen to protect your eyes, and tell me a little bit about your diet.
My personal diet.
Yeah, or your personal eye hygiene. How do you stay healthy?
Well, lean protein, stay away from saturated fats, fish, lots of colorful vegetables and fruits. I stay away from caffeine, except for chocolate. But caffeine is not, in my opinion, is not good for dry eye patients. So
because why? I know our patients are going to be very sad to hear this. Why?
Yeah. So now, but again, before we go into that, if we remember the jigsaw puzzle analogy, caffeine, like I tell patients, we're gonna start you with the big stuff. We're gonna make sure your surface is healthy. We're gonna make sure you have adequate water retention. Your meibomian glands are, the scar tissue is released and they're functioning again. If you are at that point comfortable, if you're 90% better or you're comfortable, we don't have to change anything else about your quality of life. But if you still have issues, then we're going to start getting to the smaller pieces of that jigsaw puzzle, like caffeine. Now, obviously, they come in and they're drinking 5 cups of coffee a day. There are other reasons besides dry eye that they need to cut back on that. But I think caffeine can exacerbate dry eye because it's a diuretic. As a stimulant, it can increase your fissure width.
Okay.
It can.
Make your eyes open.
I think that the old model of epinephrine-induced MGD, I think caffeine can actually lead to increased epinephrine or possibly increased keratinization in the distal meibomian glands.
Interesting. Okay.
So, there are a few reasons why I think that in those patients that need a little extra improvement, in addition to tackling the major pieces of their jigsaw puzzle, the caffeine, and I won't tell them to stop it immediately. I'll just tell them, let's just cut back on it, see how you do. And if you do well, then maybe in the future we can come back up again and increase your consumption of caffeine. But I tend to not impact their quality of life if they enjoy that morning coffee. Sleeping is very important. Quality of sleep, very important. So now sometimes patients will wake up, because their eyes wake them up. Sometimes other things wake them up, but so we focus on good quality sleep. The nocturnal lag ophthalmos if their eyes are not closed while they're sleeping. So we look at sleep mask. We look at patching the eye, like an amblyopia patch or that kind of thing.
And what's your daily routine? What do you do for your eyes?
This is also important. I'm glad you asked that question. This is also very important. One of the major risk factors for MGD, in my experience, is poor hygiene, poor facial hygiene, poor lid hygiene. And I see this, and it's not just crusting on the lashes. It may be flaking on the lids. And so you ask patients, do you clean your face every day? Well, once a week. Okay, not good. Or they'll say, I do clean every day. And I ask them, describe how you clean your face. Well, I run the water and I make sure it's a nice temperature. I said, would you use anything besides water on your? No, I just use water. Not good. So I recommend to patients to actually wash their face twice a day with something that lathers up. I like something called Stone Crop Gel Wash. I think company's called Eminence. Stone Crop Gel Wash. It's organic. It's good for all skin types. I'll have the patient close their eyes, and they lather up, and they literally, and this is what I do myself in the shower. You use your fingertips, and you go from out. I go from outer to inner, and back. That's one repetition, and I use 30 repetitions. But some patients don't need it or don't want it use that much. Maybe it may be irritating or drying if you do too much. So I'll say, why don't you start with 10 repetitions, and then after you do your lid margins that way, then clean your lids and your whole face.
And this is with warm water, I assume?
Mm-hmm. Yeah. So, and to do this twice a day. And I found that when patients do that, then their lids and lashes, it looks great. Any kind of suggestion of biofilm is resolved, and they do well. And so I can eliminate that comorbidity, which drives some meibomian gland dysfunction, simply by taking the time educating them as far as how to properly manage the hygiene of their eyelids and face.
Good points. We have about 5 more minutes, and I want to hear your opinion about the future of dry eye care. So what do you think is the next frontier? I mean, we're obviously in the middle of trying to find ways to treat it. What do you think is the future?
I think the future is having dedicated dry eye clinics. For the last 5 years, all I do is dry eye. Mm-hmm. And by that, I mean, again, it's meibomian gland dysfunction, and then those things that impact the meibomian glands. I mean, that's my paradigm now to achieve success in managing these most difficult patients as well as the ones with mild symptoms. I start with meibomian glands because they're the ones that are teetering. They're the ones that could change the patient's quality of life immediately. Mm-hmm. And everything, in my view, it's kind of like a hub and wheel. If I can focus and restore the health of my meibomian glands, and then identify and treat comorbidities, then that leads to success. So I think there's enough there now that we should have dry eye fellowships. Literally, dry eye fellowships. In other words, not as a kind of branch off from cornea and external, mm-hmm. dry eye fellowships, which means not doing corneal transplants, but just dry eye management. And I think that we're going to wind up having dry eye solo practitioners, whether it be truly solo or within the context of a larger practice. You know, it's a lot for a busy cataract or refractive surgeon to mm-hmm. take on dry eye.
That's
It's really a lot.
Yep, we hear that all the time. We hear about patients complaining about the bedside manner of this dry eye doctor and this dry eye. I'm like, well, they want to be doing cataract surgery. They don't want to be doing this. It's true. Right. You're right. That's a very good point.
So they could hire a dry eye focused doctor mm-hmm. that just does dry eye, because that's what they need. And that way they optimize the quality of care and don't take away from their cataract mm-hmm. practice or refractive practice. I mean, I see that as the future, mm-hmm. but I think the dry eye fellowships are real important. There's a lot of knowledge, a lot of information out there that's not being shared. You know, there's so much information in all branches of ophthalmology, but if you're interested in dry eye, it's a lot to take on. Mm-hmm. It's a lot to take on, and especially if you're in the middle of a busy practice mm-hmm. in other areas. So that's what I see in the future.
Absolutely. Yes, you're absolutely right. I mean, I don't know how many children you see every day or every year, but we're seeing so many young people coming in and they're 6 and 7 years old and they're losing their glands at record pace. And we see that when we were kids, we didn't have a cell phone or a computer, you know, and now they're in the crib with their computer, and I just can see the problem. So you're absolutely right on that. Any parting words of wisdom for all those, let's say, doctors that are interested in dry eye and want to kind of pursue it a little bit, and as well as for patients that are looking for the right eye doctor to help them through this?
I think that if you're guided by the cause, the proximate cause, and guide your therapy as to what is causing the symptoms. When you're treating dry eye, generate a root cause analysis. What's the root cause of the symptoms? It's going to be MGD, ATD, allergy, antioblepharitis, lack of sleep or eyes open during sleep, khaleesis. Identify the root cause. Don't look at dry eye as a general inflammatory disease without breaking it down into its root causes. Because you want to, in my experience, target each root cause. If you can target each root cause, you will have success. If instead you just give the patient an anti-inflammatory therapy and say good luck, you're not going to achieve the level of success and sustained success and help that patient understand why they had a hiccup, for example, in their symptoms. You're just basically giving them something to mask the problem. I had a patient came down from Massachusetts some time ago that was told they had neuropathic eye disease. Turned out not the case, had occult disease. Went back up north and had a hiccup like 6 months later and was doing great, then had a hiccup. And he was upset about it because his eyes started bothering him significantly. And so we talked on the phone, and it turned out that we took a careful history, and we traced back when the symptoms began, and to look for what could have tripped him over. In other words, what could have caused his meibomian glands to stop working properly. It turns out that he was with his daughter on a walk in a park, and they were stopped behind a bus. And he remembers this, as we meticulously taking that history, he remembers the bus exhaust blasting his eyes. But he didn't think of it at the time. So all he knows is that night his eyes started bothering him really, severely. And he called me the next day, and we went, when did your symptoms begin? Last night. Okay, let's trace back from when they began 6 hours before then. What'd you do? Where were you? Let's trace everything back. And if you do that, you can typically identify something in the environment that they were exposed to that triggered it. Or maybe the doctor put them on a new medication. But if you walk them through, and it's important not just to make that diagnosis, but it's important to educate the patient that they have the power and control to analyze their own lives, to be their own detective, their own doctor, and to figure out what they did wrong to knock them off the track, knock them off the rails, to make them symptomatic once again.
Very good point.
And if they learn how to do that, then they'll be able to manage themselves for the rest of their lives, no matter what happens to you and me and the other doctors that are interested in helping these patients today. So educating the patient is very, okay, which ties into something else you asked about the future. The future of dry eye care is also having an educational piece where we have educators, so that when we talk to patients and share our insights and our treatments and then leave the room, there's someone educated and come in and say, because invariably these patients will forget half of what we tell them.
A lot of information.
A lot of information, and we've got to go on to other patients. So we need educators. I see in the future dry eye educators that are knowledgeable in how to extract that information from a patient that, they were just stopped behind a bus and the bus exhaust blasted their eyes. Those are the kinds of things. That's a very important piece as well.
Great. Thank you so much, Dr. Maskin, for your time. This was wonderful. I've learned so much myself. I hope our patients will really benefit from this. And so I ask all the audience to please send this on to friends and family. And, of course, look up Dr. Maskin at his wonderful website in Tampa, Florida as well. If you have any questions, please email me. And I hope to do this again, Dr. Maskin. Would you be willing to come back maybe in a few weeks or so? I'd love to do this again.
Of course. Thank you very much.
Thank you so much for your time. This was awesome. Thank you. Okay, everybody. Thank you. Have a great night. A great day. Bye.
Bye-bye.
Thank you, Dr. Maskin. That was really,
Thank you.
really helpful.
Thank you.
Thank you.